Hello, I'm Rachel Hansford, ACNR publisher. Welcome to our Neurovoices podcast. In this episode, I'm speaking to Professor Guy Leschziner about sleep. I'm sure most listeners already know that Guy is an authority on the subject, but perhaps I can ask you to introduce yourself, Guy.
Yes, I'm a professor of neurology and sleep medicine at Guy's and St Thomas's, and I work between the Department of Neurology and the Sleep Disorder Centre at Guy's.
And obviously, you're very well known in the field of sleep. And you gave a talk at the ABN conference recently on managing sleep disorders, which was aimed at general neurologists, I think. Perhaps you could tell us a little bit about that talk for the benefit of people who went there.
Yes, so as neurologists, I think we have some understanding of issues surrounding sleep, but across the board in medicine, there are significant limitations to how good our education is surrounding sleep medicine, yet we all see patients with sleep disorders on a very regular basis. So the aim of the talk was really to identify some of the pitfalls that general neurologists might encounter within their general neurological practice in order to try and facilitate identifying sleep disorders properly and getting patients on appropriate treatment.
You talked before about the lack of training. Is that a key issue? So the people that were at the ABN were obviously wanting some practical advice, perhaps about the common questions that they would ask in the clinics.
Yeah, so when I was at medical school, I don't remember any training at all surrounding sleep medicine. And actually, even as a registrar, we got very, very limited education around sleep medicine and sleep disorders. And I think that is not an isolated experience. I think that reflects medical training historically, generally. I think we've got a little bit better at disseminating information about sleep medicine, but only a little bit. Yet, despite that, from a research perspective, we're really beginning to appreciate how important sleep is for every aspect of our psychological and physical health, including a whole array of neurological disorders. Yet, even now, I think a lot of my colleagues perhaps feel somewhat underconfident in the approach to patients with sleep disorders.
So in your talk at the ABN, did you give advice on how to approach that patient? What kind of questions would they be asking to differentiate
Yeah, so
insomnia and sleep disorder?
So I covered a range of sleep disorders, talking about the common pitfalls, but also some of the advances in the practice of sleep medicine that my colleagues may be not necessarily entirely familiar with. I talked a little bit about how to approach individuals with insomnia and to ensure that indeed the diagnosis of insomnia is correct, how to try and treat insomnia, because I think there has been a sea change in terms of how individuals with insomnia are treated nowadays compared to a few years ago. But I also talked about some of the diagnostic pitfalls in terms of narcolepsy, in terms of the parasomnias, and some of the therapeutic options that are available for the treatment of individuals with narcolepsy and the parasomnias and indeed restless leg syndrome as well.
And at what stage should a GP refer someone to you in the sleep clinic?
So obviously, sleep medicine still in the UK is relatively underserved, and so it is very clear that we cannot see every patient who has a sleep complaint. And in fact, sleep complaints are the commonest things that are mentioned in a primary care consultation. So without wanting to break the system, it's really important that referrals are made judiciously. I think GPs are increasingly becoming skilled at identifying those patients with insomnia, perhaps not necessarily um, as good at identifying those patients in whom an underlying other sleep complaint is mimicking insomnia. And I guess the key indications for referral are if somebody is excessively sleepy during the day, because the vast majority of individuals with insomnia will be tired, will be fatigued, will have cognitive symptoms, but will not be excessively sleepy during the day. They will not drop off. So I think that's a really important warning sign that perhaps what you're seeing is not insomnia. And then, of course, there are other symptoms that individuals may describe that are very much in keeping with other sleep conditions rather than insomnia. So features of obstructive sleep apnea, restlessness or sensory symptoms consistent with restless leg syndrome, parasomnia, so unusual experiences at night. And it's really the bulk of those patients that should be referred to a sleep clinic, depending on whether or not there is a very clear feature of obstructive sleep apnea, in which case a respiratory sleep clinic is perhaps most appropriate. Or if you think that somebody's got narcolepsy or a parasomnia that is difficult to control, or may have restless leg syndrome, for example, then getting them to a neurology clinic would be appropriate.
In 2021, you were interviewed by Anne Donnelly, ACNR's editor, at the time that you published one of your books, The Nocturnal Brain: Nightmares, Neuroscience, and the Secret World of Sleep. It's really interesting looking back at some of the things, because Anne suggested at the time that sleep appears to be an underexplored area of neurology. I just wondered whether you
Hmm.
feel that's changed. I mean, ours, just as a plug for our own ACNR series, we have since 2016, we've had a sleep series of articles edited by Kirsty Anderson. So we had, sleep in Parkinson's disease, sleep in brain injuries, that kind of thing.
Mm.
And I just wondered how you feel about how things have changed over the last few years. Do you feel like awareness has improved?
Yeah, I definitely think awareness has improved. I think that there is much more interest in the neurological community about sleep, and in particular, the intersections between sleep and neurodegeneration, sleep and Parkinson's disease, sleep and epilepsy, sleep and migraine. So definitely things have changed. I remember as a registrar kind of creating my own fellowship between Queen Square and St Thomas's in an effort to try and learn a little bit more about sleep medicine, and being viewed somewhat quizzically by some of my colleagues as to why on earth I was doing this, because it was very much seen as a sort of a peripheral passing interest. I think those days are gone. I think, we now have several neurologists attached to the sleep disorder centre at Guy's. When I joined Guy's, the sleep center was entirely staffed by respiratory physicians. And now we have, several neurologists. We have a neuropsychiatrist, a psychiatrist, respiratory physicians, a whole range of other subspecialties that are contributing. And so I think that, first of all, there's a recognition that sleep medicine is a multidisciplinary field. Secondly, people have begun to appreciate the role that a neurologist can have in managing patients, with some of whom are pretty complicated, not only from a physical perspective, but also from a psychological or psychiatric perspective. And I think that having neurologists involved in the management of this patient cohort is really important. I would arguably say that neurologists perhaps have the most to offer, although I'm sure my psychiatry colleagues would disagree violently with that statement. So I think that certainly the interest, both from a clinical perspective and indeed from a research perspective, has grown exponentially since I spoke to Anne those years ago.
And can I ask what got you interested in the topic in the first place? Where did your particular interest in sleep come from?
Well, I know I said I got no teaching at all on sleep in my medical education. Actually, I did an intercalated degree, and one of the modules that I did was psychological physiology. And one of the first subjects that we were asked to write about was, why do we dream? And it struck me at that time, well, I've got absolutely no idea. I don't think many people had. There were a few ideas at the time. But it also made me think about, well, why do we sleep? Because, at that time I was probably 19, and I thought, well, sleep just makes me feel less tired. And then there was this sudden realization that, actually there must be more to it than that. And going through my training, and I did a PhD in epilepsy and epilepsy genetics, it became apparent the role that sleep had in terms of the management of patients with epilepsy, but also in terms of the differential for epilepsy in the night, all the parasomnias. And, through my training, I was very fortunate to be attached to the epilepsy unit at Queen Square, and also doing some training at Guy's and St Thomas's, which at the time had one of the foremost sleep services in the country. And so it was exposure to all of these patients that really made me want to pursue it from a clinical perspective.
I think you've said that interest has increased exponentially. Do you feel that the topic is well covered in general conferences like the ABN?
No. It's a very short answer.
Yeah.
I think that things are changing a little bit, but I think we've got quite a long way to go. Interestingly, at the ABN, it was announced that they were launching a specialist interest group in sleep, which I think is really very, very helpful. And of course, the ABN president-elect, Sophia Eriksson, is very active in sleep, and I'm sure she will make significant changes, which I think will be very, very welcome. And, as I said before, sleep intersects with pretty much every aspect of neurology. And so there is some applicability to whatever subspecialty you practice.
I was struck by in your
Hmm.
interview that we published in ACNR, and I quote, "When we're in a 30-minute appointment, we don't discuss many of the aspects of their life and how their disorder interacts with that life. We don't discuss many of the family and social issues that we perhaps should do if we have more time." And you commented that writing the book had made you think about what you do in your clinical practice more. And I just wondered if you had any examples of changes that you made to practice as a result of that.
Yeah. So I think, I'm very fortunate because my sleep clinics in the NHS are tertiary referral clinics, and so I have a little bit more time. And I think part of the drive to get more time is to allow a more holistic evaluation of the patient, because of course sleep in general terms, is a confluence of biological factors, of psychological factors, of social and environmental factors. And it's really important to understand all aspects of that patient's life when it comes to trying to manage their sleep. So it is a question of time, unfortunately. We need to have the time to be able to speak to our patients properly and fully. And I think the current pressures of the NHS and the admin associated with it, I think, if anything, are increasingly detrimental to allowing us to do that job properly. So in terms of my own practice, well, it has been a long and difficult road to try and give myself more time to do things properly. And I realise that I'm in a very, very fortunate position.
I did really like the way in that interview that you talked about involving the patients and telling their story. And I thought that was really interesting.
One of the key aspects of my non-clinical work, I think, is about public engagement. And in order to engage with the public and try and communicate science and communicate medicine to a wider audience, it is about the personal aspects of medicine, because quite frankly, there are a lot of people out there who are interested in medicine from the human perspective, perhaps more so than from the scientific perspective. And in order to do that properly, in order to tell the human story properly, I think you have to be as comprehensive and as honest as you possibly can. Now, obviously, as doctors, we are bound by medical confidentiality. And, a lot of the time we write, we do it in a very anonymized fashion, a very depersonalized fashion. Whereas I think in the engagement of the public, particularly that large section of the public that perhaps is not so interested in, neuronal circuits and neurotransmitters and electrical activity, the only way to properly do that, I think, is in collaboration with your patients, because that allows you to be as comprehensive. It allows you to avoid that anonymization. It allows you to be as honest and as frank as you possibly can, which, without that process is very difficult.
Have you noticed any impact
Hmm.
long term from the COVID pandemic or the changes that happened in the way that we work? So I'm thinking about working from home, that kind of thing.
Yeah. Look. I think that everybody initially was very happy to be working from home a little bit more, but I think most of us have realised the limitations of spending large chunks of a time looking at our patients on a computer screen. And certainly, within our own department, we have gradually moved much more away from that kind of remote consultation model. I think that there is a cohort of individuals for whom that works really very well. And of course, when it comes to convenience for patients, there are some patients for whom it's clinically appropriate, but also in terms of their quality of life, doing things via telephone or via video is really beneficial. But I think the default position should still be that we are seeing patients in a face-to-face setting, because there are certain things that you cannot get from a video or a telephone consultation. And from my own perspective, I've found endlessly sitting on the telephone or on a Zoom call actually quite detrimental to my own enjoyment of medicine. So I think that there are clearly some very good things that have come out of COVID, because I think the increased flexibility of how we interact with our patients has been good. It's really led to an acceptance that not every single consultation should be face to face. But I do think that we are now hopefully reestablishing a middle ground rather than seeing everybody face to face or everybody remotely.
And do you think it's had an impact on people's sleep? Have you seen changes in the kind of referrals that are coming
Hmm.
to you in the clinic?
I think there are many more patients who have developed sleep disturbance in the context of, post-viral fatigue syndrome or long COVID. Of course, at the moment, there remains some ongoing debate as to the precise nature of what long COVID actually is. My own view is that it's probably a very heterogeneous condition. That there are some individuals who have many features of functional symptoms, but then there are also other individuals who have, much more organic type picture. And so there has definitely been an uptick in terms of individuals who have presented with autonomic disturbance, gastrointestinal disturbance, a sort of POTS-like syndrome associated with significant insomnia.
And you think that's connected to the virus?
I think the honest answer is I don't know. There are some people who clearly have had a significant deterioration in their physical health. I think there are some people who've had a significant deterioration in their mental health. COVID was a particularly stressful and trying time for many individuals, and led to significant changes in terms of their social network, in terms of their mental health. So I think that there are a variety of different factors that, for certain individuals, has resulted in a breakdown of their sleep.
How important are genetic determinants of sleep? So, like, are we slaves to our genes? I noticed you said in your interview
Hmm.
you wrote for ACNR that some people are more predisposed, perhaps, to having sleep problems.
Yeah. So we know that genetic factors are very important when it comes to sleep. They define our chronotype, whether or not we're morning larks or night owls. We know that genetics is important for defining what our sleep requirement is. We know that genetics is important in terms of risk factors for conditions like restless leg syndrome or obstructive sleep apnea, even because certain genes influence our airway anatomy. So it's very clear that there is a very strong genetic component. Insomnia has got a very strong genetic component as well. But as with all things, it's an interaction between the genetics and the environment. So just to give you a very basic example, you may have a very low genetic contribution to restless leg syndrome, but if you're very iron deficient, then you will have restless leg syndrome. You may have a very low genetic predisposition to obstructive sleep apnea, but if you put on huge amounts of weight and become morbidly obese, you are quite likely to get obstructive sleep apnea. So we are, of course, we are slaves to our genes, but we're also slaves to our environment. We've moved towards a society where we track everything, we measure everything, and actually that can, for certain individuals, be deeply unhelpful when it comes to sleep, because it can actually generate problems rather than solve them.
Yeah, that's interesting actually, because one of the questions I had for you was about technologies, about how
Mm,
that might change clinical practice, but so people who have the smartwatches that monitor their sleep, is there any benefit?
yeah. Well, I think the answer to that is complicated. Certainly I very much shy away from the use of sleep trackers for individuals who have insomnia, because what tends to happen is, if you're already worried about the fact that you're not being able to sleep when you want to, that you're not getting enough sleep, having a sleep tracker telling you that you're not getting enough sleep is not going to allow you to do anything specific to try and improve the situation. In fact, it may worsen the situation. Um, if you have other conditions, like, for example, obstructive sleep apnea, there are some commercially available trackers that allow you to see, um, how bad your sleep apnea is, whether or not there's a clear association between you drinking alcohol and your sleep getting worse, whether or not using positional measures to try and keep you off your back might improve things. And so, in those settings, actually, sleep tracking technology may be rather useful. I think that the biggest opportunity for the use of these sleep trackers is actually in these large longitudinal studies that historically have always relied upon patient reports of sleep. And we know that we are very poor witnesses to our own sleep, and that what somebody tells you about their sleep and that the reality of objective measurement may be vastly different. And I think that that has created quite a lot of confounders in the field in terms of understanding associations between sleep and other outcomes. And so actually, now that we have relatively cheap, widely available objective markers of sleep, or at least proxy markers of sleep, it is going to be a very useful research tool.
Can you give us any examples of recent research which you think will have an impact in the relatively near future? I mean, you talked about in the interview that you did with ACNR, you talked about stimulating lucid dreaming or helping people who are having nightmares because of PTSD.
Yeah, I think that there is a field called closed loop auditory stimulation, which I think is rather exciting. This is about using auditory brainstem evoked potentials to manipulate sleep architecture and actually to potentiate delta waves in slow wave sleep. There has been some preliminary data that has demonstrated some changes, including some cognitive changes associated with that. I think that there are significant developments from a therapeutic perspective and sleep. So, both in terms of our understanding of the association between drugs for insomnia and cognitive decline later on. So, there's a recent study demonstrating that zolpidem seems to influence the functioning of the lymphatic system, which may give us some explanation as to why some of these drugs may give rise to cognitive decline later on in life. And in terms of novel therapeutic options, for example, in narcolepsy, there have been really major changes. And in fact, this is one of the things that I talked about in my talk at the ABN, was the fact that hypocretin or orexin agonists are now on the horizon as a treatment for narcolepsy, which I think will really revolutionize the treatment of narcolepsy, because certainly the early indications are that these are extremely effective in terms of establishing control over narcolepsy to a degree that existing therapeutic options don't seem to be able to achieve.
And do you have any sense of how long it's likely to be before they're used in clinical practice?
Well, there was a study with a recent agent that worked extremely well, but unfortunately caused liver dysfunction in a proportion of individuals. But there are about 3 or 4 new molecular compounds that are now entering into phase 2 and phase 3 trials. So hopefully, within the next sort of 3 to 5 years, these drugs will become available for individuals with narcolepsy. And I do think they are going to be quite revolutionary.
Can you give me an example of what kind of problem someone comes to the clinic with, and then the kind of questions you ask, and what a process they go through looks like, and what kind of what success looks like in the clinic.
Yeah, I think that's rather difficult because there's such a disparate set of conditions and symptoms that people come in with. That's the problem. So it very much depends on what the primary issue is. Is this the first question that we ask whenever we see a patient with a sleep disorder is, look, is this primarily an insomnia? Is it the fact that this individual is having difficulty sleeping when they want to, and are there consequences to that? Is it the fact that they are just sleep deprived, that they're able to sleep whenever they want, but they're just not giving themselves enough time in bed? Um, if it is insomnia, is this what we would previously have considered psychological insomnia, or is there something else that is underlying it, like sleep apnea or periodic limb movement disorder, or could it be that their circadian rhythm is misaligned? So the fact that they are trying to go to sleep at 10 o'clock at night and they can't, is that a function of insomnia, or is it the fact that their internal body clock is set at a different time to everybody else's? Then there are those individuals with hypersomnia, so people who are excessively sleepy. So the question is it because they are sleep deprived? Is it because something is disrupting their sleep? Is it because they've actually got a neurological disorder like narcolepsy or idiopathic hypersomnia? Could it be iatrogenic? So could it be the fact that they're on drugs that are sedating them? Could it be that actually this is intrinsically tied into their psychiatric state? So is this what we would term psychiatric hypersomnolence? And then there are the third major group of individuals who are those with parasomnia, so people who are doing unusual things at night. And the question is always, well, is this a function of sleep? So is this related to REM sleep, as in REM sleep behavior disorder? Is this a function of non-REM sleep, as in a non-REM parasomnia? Or could this be a form of nocturnal epilepsy called sleep-related hypermotor epilepsy? And so, the starting point is always with identifying the core problem that the patient is experiencing and then trying to unravel that. And that's done through clinical history. So looking for pointers in terms of for example, the timing of their events, the semiology, the nature of their events. Are there aspects of the psychological status or the social or environmental factors that might be contributing to this, and then deciding appropriate investigation. So is this a question of trying to ascertain what somebody's biological clock is set to? Is it a question of just looking at their sleep overnight to see whether or not there is something disrupting their sleep? Is it trying to understand whether or not they are excessively sleepy despite having a very good night's sleep? And that's a test called the MSLT. And indeed, in my talk, I talked about some of the issues surrounding the interpretation of that diagnostic test. Or is it something that we need to dig into deeper? So, getting brain imaging, getting MRI scans, or even PETs to try and understand whether or not they might have an epileptic focus, doing EEGs, that kind of thing. So there are lots of different pathways down which one can descend depending on the clinical picture.
Brilliant, thank you. Just before I let you go, though, I know that you published a new book at the end of last year. Perhaps you could tell us a little bit more about that?
Yeah, the book is called Seven Deadly Sins, The Biology of Being Human, and it explores the classical seven deadly sins of Christian theology from a biological perspective, looking at the psychology and the neuroscience of why we behave badly and what that tells us about the nature of free will. A lot like my previous books, it's very much done through the perspective of patient stories and patient experiences. And as with my previous book, it's been in collaboration with some of those individuals. And I think for anybody who is interested in neuroscience, I hope it's an interesting read.
Sounds great. I'll look out for that. You've been listening to ACNR's Neurovoices podcast. If you want to hear more from us, you can sign up for our emails on our website, acnr.co.uk. You can join our online community at forums.acnr.co.uk or follow us on socials.